to the emergency department for COVID testing. There are several sites in the region that offer testing with no out-of-pocket expense to the patient, and patients shouldn't be coming to the emergency room if it's not an emergency. And for non-emergent issues, there are also several other levels of care, such as primary care physicians, urgent cares, or virtual services like our 24/7 virtual urgent care that can be used for situations that don't warrant an emergency room visit. So there's access to free testing in the community, and on behalf of our physicians and ER staff, we would implore the community to utilize those other resources versus the emergency room, primarily for testing. So with that, I will turn it over to Cliff to get started for this week.
Thank you, Lauren, and thanks everybody. We'll briefly run through this week's data.
Fasenra is a different kind of asthma medication. It's not a steroid or...
Oops, hold on. There we go. We'll briefly run through this week's data, and then I've got a couple of pediatric colleagues that are joining me on the call today, and we'd like to spend some time or reserve some time for them to provide you some additional information. As you can see, our peak of 305 this morning is within shouting distance of our prior peak back in early 2021, and this is no different from what we're experiencing, what health systems and communities are experiencing around the country. It has been a pretty rapid increase in the number of people infected, and then that's a leading indicator. The lagging indicator is the number of folks that end up getting sick enough to require hospital support, require hospitalization. This just shows you where we were. The red line is our COVID positive inpatients this year versus in 2021. And again, we're at a place that we haven't been at in terms of the number of infected individuals inside our hospitals. This you've seen, it just shows you in a different format the data. What's important to note is there are fewer people on a percentage basis requiring mechanical ventilation than we saw in the prior waves, the Delta, or even in the first wave back in the early 2021. So I guess that's the good news, but not for folks to underestimate or discount how serious this infection can be and is in many people, because we have got a substantial number of folks that have been admitted to the hospital for oxygen support. What seems to be a pattern that's played out around the country is playing out here is a smaller percentage of those patients move on to be so sick and have such trouble breathing that they require a ventilator. So that is holding true for us. You see it in our numbers as well. The average age is up a little bit over the last few weeks in terms of the average age of the individuals both in the hospital and or requiring mechanical ventilation. So I think that's, and this is our tested, we added this slide just so you can see this dramatic surge. So this is coming out of our lab. It's our test positivity rate. And so, this 49%, which we recorded on the testing coming through, is obviously, north of double what we were running. And our prior peak, we were only in the 30 to 35% test positivity. So this is definitely different. A lot more people have been exposed to this variant, and obviously a lot more folks are infected. So I think that's all we had on for my part, and I'm going to now turn it over to one of my colleagues. I don't know if Dr. Tukaram is first, but I'll put her on the spot first, and then we'll let Dr. Lukman follow up.
Thank you, Dr. Robertson. I think this COVID increase in our hospital, especially this past week, where we're seeing increase in the number of cases. And in fact, interestingly, 75% or more are actually infants, about 12 months of age or less than 12 months of age. And the variation in the symptoms are ranging from severe croup to just presenting with dehydration because of decreased oral intake, needing increased level of oxygen support, infants having vomiting, diarrhea. So all different spectrums, and daily pediatric COVID-19 related hospitalization is in fact almost doubled in the last month. And as we know, the initial catalyst was Delta variant, and now it's substantially followed by a recent surge of the Omicron variant. And interestingly, if you look at the vaccination rates among the pediatric population, it just continues to lag. And we just have, I think even nationwide, about a third of our eligible kids between 5 to 17 years who have been vaccinated. And in fact, virus is now about the top 10 causes of death for children ages 5 to 11 years. And, American Academy of Pediatrics do report a sharp increase in this pediatric COVID-19 cases. And me working in a pediatric intensive care unit, I do see serious illnesses from COVID, although rare. The sheer number of new cases worries us. And when we talk about mortality in pediatric population related to COVID-19, since the beginning of the pandemic, it's over 120 cases. And although this seems less, I think every pediatric death is unique in its own way. It's very tragic. So I strongly advocate to follow precautions and to, advocate for vaccination. In terms of, severe cases that result in fatal outcome, there are children with high-risk population that involve kids with high-risk medical complexity, with neurologic conditions, metabolic conditions, cardiovascular disease, obesity, diabetes, asthma, sickle cell, and are very fragile kids who are on chemotherapeutic agents for their underlying cancer. So I think it's very key for us to recognize that although reportedly the symptoms could be mild to moderate, there are severe cases. The incidence rate is similar to those of adults, and we have to look at that more seriously and follow the necessary steps to avoid transmission, to protect ourselves, and to protect others in the community.
Thank you. Thanks. And I neglected to more formally introduce you as one of our, obviously one of my colleagues, but one of our faculty and pediatric intensive care physicians. So you are truly on the front line in terms of dealing with the sickest of the sick in terms of children that are presenting to our hospital. Next is Dr. Lukman, who's one of our pediatricians. And so he can share a little bit of his perspective from obviously from more oriented toward the outpatient world, but we thought it would be important for you to hear from him as well.
Thank you. So I'm John Lukman. I'm one of the Warren Clinic pediatricians. Was hoping to give a little perspective on what we're seeing in the outpatient setting, because it is a bit different from the hospital setting. We are seeing a rapid and impressive increase in our COVID-19 numbers due to Omicron. As Dr. Thikaram mentioned, this started to increase with Delta, and then certainly over the last 2 to 3 weeks, our positivity rate has gone up significantly. In the health system, as Dr. Robertson mentioned, our positivity rate is near 49%, but I'll comment that in my office last week, we had a day that our positivity rate was 85%, and we had another day where it was 92%. So the number of patients that we're seeing in our pediatric offices are drastically increased, and this is worrisome. So from the beginning of Omicron, they were saying that this was a more transmissible variant, but everyone was saying that it was a mild variant as well. Interestingly, that's not necessarily what we're seeing in pediatrics. We're seeing an increase in hospitalizations. We're seeing our patients under 4 years old have croup-like symptoms where they're requiring, either steroids or breathing treatments to help them to breathe. And we're seeing dehydration rates increase, requiring hospitalization. So this is becoming an increasingly worrisome state for our pediatric patients. And as mentioned before, we are just very strongly recommending the COVID vaccine for all of our pediatric patients 5 years old and above. And then once 12 and above, getting that booster as well, per the CDC guidelines.
Thank you. Thanks for that. I think now we will open it up. Lauren, if you want to, if there are any questions that we can try to respond to.
I've not seen any questions in the chat yet, nor in the Q&A section. We'll give everyone a couple of seconds to enter their questions if they have some. Oh, we have someone with several. Let's go. Jeanette, would you rather ask them not in the chat? We can unmute you if so.
Yes. Okay, so first and foremost, is there a specific age group where you guys are seeing the increased number of COVID positive cases? Would you guys say that that is the younger than 5 years old age group?
I'll comment that we're seeing our positivity rate increase for all pediatric patients. So 18 and below, the number of them coming back positive is really impressively high, which is far different than last year. Last year, we were having parents test positive and we test the children and they somehow remain negative. Now it seems like everyone's testing positive, including the youngest children.
Thank you. My other question is currently, the Children's Hospital, how many COVID-19 positive cases are ICU related?
So we currently have about 97 cases total from December, 37 reported in December and 60 in January. And they're all across the age group, about 5 to 18 years, and about greater than 90%, in fact, 100% of them are unvaccinated. In our kids who present to the pediatric ICU, as a pediatric intensivist, I usually deal with acute life-threatening injuries to chronic diseases. And what I'm seeing is these patients present with acute respiratory failure, where they need oxygen support in the form of high flow nasal cannula support, to CPAP support, to BiPAP support, to actually intubation and mechanical ventilation. They do present with myocarditis, cardiogenic shock, altered mental status, seizures related to brain inflammation like encephalitis. Many times we see our children progress to acute kidney failure. So this is not something that's to be taken lightly. And again, as I mentioned, it's mostly in our underlying medical complex condition patients who are on mechanical ventilation for a prolonged period of time. And what I would stress also that recovery from an acute COVID illness does not end there. It takes long-lasting effects in terms of physical, mental, social well-being that can be very distressful for the child and for the family. And our patients who are on mechanical ventilation for a long period of time need a long period of pulmonary rehabilitation as an outpatient. They are sedated, they're bedridden when they're on mechanical ventilation, so they need a lot of physical rehabilitation. So there are a lot of consequences. And I think we're just touching on the surface. There's yet more data to come to see what other long-lasting sequences are there secondary to the COVID-19.
Thank you. I know that Russell is up next, but I have several more questions after him.
Well, and I would just, let me clarify one thing, not clarify, but just add to what Dr. Thakaram has just said. So in the entire month of December, there were 37 kids admitted to the Children's Hospital with COVID. So far in January, there's already been 60. So it gives you a little idea of just how much more prevalent this illness has been, and obviously the number of children requiring advanced care has increased dramatically as well.
Thank you.
You guys hear me okay?
Yeah.
So first, Jeanette, thanks for deferring. I appreciate the chance to jump in. I just have a couple quick questions. One, obviously, at this point, we cannot vaccinate our children 5 and under, I guess 4 and younger, nor are they necessarily able to verbalize their feelings or their complaints very well. So for parents of children that age, it sounds like symptomology is all over the map. What can they be looking for and saying, okay, now I definitely need to get this kid in for a test, or I definitely need to get them into, to see the doctor? High fever, what should they be looking for? Is because I know there's also more flu going around. There's other stuff going around. How do they know?
Dr. Lukeman, do you want to take this one?
Sure. So as you mentioned, there are a lot of viral infections going around right now, and we are seeing a lot of sick kids from flu, adenovirus, or common cold viruses, and then of course, Omicron variant of COVID-19. A lot of those symptoms can mix between those viral infections. And so what I would tell parents to look for is something worse than the common cold symptoms. So if they're having a mild runny nose with no other symptoms, no exposures that they know of, they're probably okay to monitor that. But anything further than those symptoms, it would be wise to have the child tested and likely seen by their pediatrician. Again, we're seeing a mix of symptoms, but most of our children under 5 years old are having a lot of upper airway symptoms. So runny nose, congestion, cough. And then again, with Omicron, we're seeing this very specific croupy cough, or a barking sounding cough. Now, to further answer your question, when does a child definitely need to be seen? Whenever they're having difficulty breathing, taking in breaths, whether they have a rapid respiratory rate, or they're having a hard time taking in deep breaths, or if they're having a hard time eating and staying hydrated, all of those things would require a more urgent exam.
All right, one follow-up, and then I'll give it back to Jeanette. When and I had it in my brain and now it's gone. So when these kids get these infections, are we seeing a combination? Are they getting, COVID and the flu, or have we seen any of that kind of activity? And obviously, again, we can't vaccinate these kids. So I'm going to presume the best way is to just kind of keep them socially isolated to try to prevent them from getting COVID. I mean, it seems like a tough call.
Yeah, so, COVID-19, we say, is like the king of the respiratory viruses, but there are so many other viruses in the royalty panel. So we have, human metapneumovirus that we're seeing a lot, adenovirus, flu virus. And you're absolutely right, in the respiratory community, viral pathogens, there's definitely overlap of symptoms. And our little ones who are less than 2 years of age, it's hard for us to have them keep the masks on or to socially isolate them. But I think following precautions, like an adult around them, if they're sick, then stay at home. If your child is sick, then keep them home and don't send them to school, just to mitigate the transmission. The kids need to have their social life. The kid needs to have their activities. So you cannot isolate them or cause more social isolation or prevent them from interacting from friends. But I think a simple precautionary measure, both followed by their, the adult parents, the friends who are older age group of greater than 5 years of age, I think that would help mitigate most of the symptoms, not only related to COVID, but also the other viral pathogens that are there in the community. And Dr. Lukeman is absolutely right that if the child presents with nasal congestion, fever, cough, then you're advising parents to hydrate, kind of monitor for those symptoms. But then you start having any kind of color changes, like appearing pale or kind of dusky around the lips and stuff. So those are the times that they need to seek emergent care, or they're getting dehydrated. The number of wet diapers are low. They're not taking enough feeds. They're vomiting. So you need to get ahead of the game to bring them to the emergency department and seek appropriate care.
All right, thank you.
Okay. There is one clarification question in the comments that I will throw out to Rupa. I'd like to ask for clarification about the January cases, the 60 admissions so far. is it 75% of those patients who were 12 months or younger?
Yes, and speaking with my hospitalist colleagues, that's what they're seeing is 75% of those cases are 12 months or younger.
Thank you. Jeanette, I think you're ready for your next question.
I am, thank you. So you guys mentioned that you guys have 60 cases as of this month that are ICU COVID-19 positive cases. Is that correct?
We've had 60 admissions for the Children's Hospital.
The Children's Hospital. Okay.
Yeah, not in the ICU, sorry.
So are those in addition to the 37, or has it increased from 37 to 60?
It has increased from 37 to 60.
Okay, perfect. And out of those 60, right now, is the Children's Hospital at capacity when it comes to ICU beds?
No, we're not at capacity. We can still admit more patients and take care of them. And it's a rapid turnover for us. So we may have a child who's admitted for a whole different diagnosis, and we land up testing them and they're COVID positive. So those are the patients we know who are not significantly ill. So then we are doing supportive care for them and then moving them out of the ICU. So we still can make the beds available, but we just work in an efficient way so that these really sick ICU patients are adequately staffed to be taken care of.
So as of right now, out of the COVID positive, how many of the ICU are COVID-related ICU patients?
So I would say as of now, they're about 40%. And just, I worked last night and I got 3 more admits who were COVID-19, and that ranged from a cardiogenic shock all the way to acute respiratory failure, encephalitis with seizures.
Perfect. Okay, and then my other question, obviously you guys are not at capacity, but I know that there are other major hospitals, children's hospitals like Cook Children's in Fort Worth, where they are at capacity. So if you guys would have been at capacity, I would have asked where are you guys sending them, but that's not the case. So let's see. What other illnesses in addition to COVID are you guys seeing? I know flu, RSV, and how does croup differ from the other illnesses?
So croup is more of an upper respiratory inflammation. We call it as laryngitis. So you have barky cough, may need some oxygen requirements, some steroids to help cut down the inflammation and swelling. If you have an RSV infection, it's more of a lower respiratory tract infection. So you can have lots of inflammation in the lung. You can have inflammation in the lower airways that can cause problems and difficulty for the child to take a breath. COVID-19 almost always, apart from the croup that we're seeing now, it settles in the lungs and causes significant lung inflammation if they're presenting purely from a respiratory illness perspective. But otherwise, it has kind of a wide variety of clinical manifestations, as I just mentioned, can affect the heart, can affect the kidneys, can affect the brain. So I think that's kind of the difference that we see from other respiratory viral panel to COVID virus.
Perfect. And I know that you guys are highly advocating for children to get vaccinated, but for those who are in that age range that they're not eligible for a vaccine yet, how can parents do their best in protecting them?
Because vaccinated individuals are less likely to spread the virus and also to be less likely to be hospitalized, the best thing parents can do is vaccinate themselves and their children that are an age appropriate age for vaccine. So those are probably the best things you can do, is vaccinate your family members that can get it, but then avoiding places that are high risk exposures and avoiding contacts where you know that they have positives, wearing masks when possible. So children above the age of 2 can wear masks. So all of these things can be done together to help keep the youngest children safe.
Dr. Lukeman, I think your daughter recently got vaccinated. Is that correct?
My daughter recently got vaccinated. Yes, she's had her 2 COVID vaccines and received her second back in December and was very excited about it.
Thank you.
You posted a video of that on your Facebook page, and it's been shared quite a bit. So we can also get that clip to some of the outlets if they're interested.
I was excited to get my second shot. I will tell you that. Can I get a quick follow-up? Because I'm confused by some of these numbers. We heard X number of cases in December and then X number of cases in January. These are pediatric cases. I presume that they're admits. And then was that a total for December and then a new total for January? Is that, because I'm confused by those numbers, and the question that Jeanette asked you just confused me more.
Yeah, so this is Cliff. I'll try to clarify. So
Thank you.
the December number 37 was the total number of admissions in children to the Children's Hospital. That was through 31 days of December. Through the first 16 days of January, the total number of admissions to the hospital, to the Children's Hospital, is 60. So on pace to essentially be a 4-fold increase in admissions should this pace continue through the end of the month of January.
So these are new patients in the first 16 days of January, not holdovers from December. This is new admissions to the hospital.
These are admissions, correct?
Gotcha. Okay, cool. And these are COVID admissions.
Correct.
Okay.
These are identified as with COVID as the primary diagnosis.
Okay, one more quick one for the doctors, and thank you guys so much, because I know you're probably at the very, very ends of your ropes after 2 years of this. My understanding with Omicron is that it has tended to settle upper respiratory rather than getting into the deep lungs. Good news, generally speaking, because it's less likely to kill you if it's not deep in your lungs, but not necessarily good news for pediatric patients, because my understanding, and it's a very vague understanding, admittedly, is that younger people struggle more with upper respiratory problems than adults do. Could you address that and kind of explain the whys, if that is true, or shoot me down if it's not?
Everything you said sounds very accurate. So like you mentioned, we're seeing the Omicron target the upper airway more. And with children under 4 years old, that airway is small as it is. So when they have something targeting that area, they get swelling and have more difficulty breathing. And so that's really one of the challenges with pediatrics. Now, like Dr. Thirkaram said, we are still seeing it affect the lower lungs. And I've seen patients develop secondary pneumonias. I had one even this morning that had a secondary pneumonia with COVID-19. So we are still seeing both.
And there's another clarification question in the comments, and I think this one would be for Rupa. What is the average length of stay in the hospital for pediatric cases of COVID?
And I think it all depends on the underlying condition of the patient, how fragile the patient is. If the pneumonia is severe enough related to COVID, and if there's a superimposed bacterial pneumonia on top of that, then yeah, the length of stay could be anywhere from 14 days to 21 days, because trying to get them off the sedation medications, trying to help with physical rehab takes time by itself. But if you have somebody with upper respiratory tract infection, I think the length of stay would be at the most 3 to 4 days in the ICU. It all depends on what the manifestations are. We see the sickest of the patients related to COVID, so it can range anywhere from 4 days to about 3 weeks.
Have you guys seen any deaths as a result of Omicron among children?
I'm yet to see a death related to Omicron in children. We have unfortunately had increased morbidities, I should say, with the Delta variant, but I'm yet to see a death related to Omicron.
Thank
It
you.
looks like we're coming up on the top of the hour. Any last questions?
Not for me, and thank you guys. Again, thank you.
Thank you all.
We'll close
Okay.
it for this week, and we will see you next week.
Thanks, everybody. Appreciate it.